Hello and welcome to today's webinar. Thank you so much for taking time out and being here today. My name is Ayong and I am the Marketing and Educational Seminar Coordinator here at NeoBiotech. And today's topic is the anterior implant delayed and immediate placement soft tissue molding with Provisional with Dr. Owen Trinh. And I will go over our social media page and also make an important announcement in regard to upcoming webinars, as well as watch previous webinars and how to receive your C credits. So please don't leave and stay until the end. And we are also strongly recommended to use Q&A box to communicate with the speaker. And so we will have a Q&A session at the end. Please submit your question through the Q&A box. And one thing that I want to address is Dr. Trinh may not answer all of your questions since we have a short period of time. And let's have our Dr. Trinh to start the webinar. Good morning, Dr. Trinh. Can you hear me?
I can. Good morning, Anu. How are you?
I'm doing great. Thank you, doctor.
All right, guys. Hey, good morning and good afternoon to some of you that are on the different time zone. Let me start off to say my name is Owen Trinh, and I want to welcome and thank you everyone for attending this webinar. I hope you and your loved ones continue to stay healthy as we cautiously return to the work of dentistry. I believe that we are very resilient and we will overcome this global health crisis. So some relevant information about myself. I currently practice dentistry and teach an AHD program in the Air Force as part of my payback commitment for the health scholarship program. And I also practice in civilian practice as, on a part-time basis. I'm a board certified prosthodontist. I did my training at the University of Minnesota, where I have a lot of exposure to both periodontal and prosthodontics procedures involving grafting, placement, and restoring simple to complex full arch implant treatment. So without further ado, let me begin with explaining to you my motivation for the topic today. I just want to apologize ahead of time for the jackhammering noise in the background because the CD is currently working on the sidewalk in my neighborhood. So from seeing referral and walk-in patient with existing anterior implant from the time of my residency to now, I have consistently found that on an average, 4 out of 10 patients, the incorrect anterior implant position create less than ideal surgical and restorative outcomes, as well as creative future restorative complication when we try to rectify the situations. So here's a couple examples of poor anterior implant as a result of surgical and restorative errors. So the first example you see involved an implant and restoration on tooth number 8. We see significant asymmetry at the incisor edge due to restorative errors in the provider not fully sitting the impression coping all the way down to the implant during the final impressions appointment. Also, the implant position was angled too facial, and what this does is led to the resorption of the crustal bone and the buccal plate, which kind of manifests itself as a form of chronic inflammation, also known as periimplantitis. The second example involved tooth number 7, and you can see it's a disastrous surgical result. And the cause for this was from damaging the buccal plate during the extractions, and immediate implant was also angled too facial, which really exacerbates the loss of hard and soft tissue. And despite the heroic and very inspiring effort from the previous provider to perform the connective tissue graft to kind of mitigate the loss of the buccal soft tissue, the level of recession is still very severe, as you can see, and is really aesthetically unacceptable to the patients. And without the supporting bone directly underneath the graft, the stability of the connective tissue graft is not very promising. And what I really want to emphasize is that proper diagnosis, planning, and execution could easily help avoid these type of compromised outcome. So personally, I put heavy emphasis on the topic of surgical and restorative management of anterior implant because I honestly think is a topic of great importance to the well-being of our patient and to our standing as a clinician. So what does it take to get the best outcome for anterior implant treatment? So at the macro level, we look at the patient's medical and lifestyle. And whether it's a single or a multiple anterior implant treatment, we should pay even closer attention to these micro features I listed below because they are absolutely paramount in helping us correctly assess surgical and aesthetic risk. And I understand that other speakers in earlier webinar have already covered the fundamentals of implantology. So today I will focus on the features that I think are more relevant to anterior dental implants. So today I will be discussing the biological changes to the bone topography after extractions. And I would define the rationale for either delayed or immediate anterior implants placement, as well as their restorative implications. I will explain to you the intrinsic and extrinsic factors that are crucial to the diagnosis, the treatment planning, and the surgical placement. I'm going to talk at length about the actual mechanics of placing anterior implants in a heel edentulous site, as well as in a freshly extracted socket with the NeoBiotech drill stop design. I will reveal the risk classification for immediate anterior implants based on the availabilities of bone and soft tissue at time of surgery. And we'll show real patient surgery video and case example to demonstrate each risk classifications, and talk to you about how NeoBiotech CMI concept can help with you getting better initial stability and faster osseointegration. And then I'm going to talk about our ability to preserve the papilla and vertical soft tissue with different type of provisionalization material and protocol. And lastly, I will demonstrate the guided anterior implant surgery with the NeoBiotech guided drill kit for the clinical scenario that demand an absolute surgical precision. So first, what happened to the natural heel extraction site without the benefit of implants? So study from Lindy and Araujo found that after the extraction and removal of the periodontal ligament, we lose the bundle bone, and this leads to 2.5 millimeters of reduction of vertical crestal bones. And then later studies with the human subjects found a drastic 4 millimeters of horizontal reductions, and it happened on both buccal and lingual side, but their studies show that it's more severe on the buccal. What happens, what about the changes to the soft tissue? So in the extractions, you take out the primary periodontal fiber that hold them through physiological stimulations. You also take out a secondary fiber that's responsible for holding the positive gingival architectures. So basically, an extraction will negatively impact both hard and soft tissue. So in terms of anterior implant, we see even greater disparity in the changes of hard and soft tissue when we compare conventional to immediate implant placement. Specifically, with conventional placement, we see a drastic loss of interdental papilla height as compared to the immediate placement group. The conventional placement can further classify as early or delay. So early is 4 to 8 weeks after the extraction, whereas delay is 3 months or more. And study by Kahns and his colleagues found that in addition to the bone resorptions and the loss of papilla height after the extraction, you will have an additional 1 millimeter of facial gingival recession measured at 1 year after implant placement. And that happened for, and that's happened for the conventional placement group. In contrast, for the immediate implant group, Tarnow reported the total bone loss was limited to only 1.3 millimeters horizontally and 0.45 millimeters vertically. And this is significantly less than the amount of bone loss in the conventional placement group. Also, the immediate implant group, Kahns showed that less than 0.5 millimeters of facial gingival recession 1 year after implant surgery. And after that initial first year of recession, the peri-implant tissue level remained stable over time. So to reiterate the importance of this slide, in the case of conventional placement, the surgical side already experienced significant bone resorption and loss of soft tissue architectures. In contrast, when implant is placed immediately after the extraction, the presence of the implant as well as the immediate provisional help minimize the bone resorption and soft tissue recession, as well as keeping the free gingival tissue stable over time. So you would ask why clinicians would choose one implant placement method over another. So with the conventional placement method, you have more surgical appointment from the time of extraction to when the implant is ready to be restored. The advantage of the conventional method is you having control over the implant placement angulation, and it's more predictable to achieve primary stability because you are working with a heel surgical site. In the immediate placement, however, is often a single but longer surgical procedure and require more advanced surgical and restorative skills. And it's require more time because it's require you to often have to do grafting and make provisional on the same day surgery. So in the nutshell, we have two set of controlling factors which kind of work together to determine the surgical and aesthetic outcomes of the anterior implants. So the first determinant we look for is intrinsic. So intrinsic is how the patient is to you, is the information you collect from examination and radiographic imaging. And in terms of anterior implant, it's important that you document the availability of hard and soft tissue and the presence of any periodontal defects prior to the implant placement. And we need to also to evaluate the occlusion, particularly in patient without canine guidance or patient with a class 2 division 2 malocclusions. So in the class 2 division 2 malocclusions, you have excessive vertical with minimal horizontal overlap. And this occlusion scheme produces increased anterior joint forces, which result in loss of canine guidance and posterior deflective contacts. And over time, this causes overloading of the anterior implants. The second determinant is extrinsic, and it's meant extrinsic because it's the actual mechanic of us placing and restoring the anterior implants. And I want to emphasize that above all else is the priority that we have a correct 3D, three-dimensional implant position and angulation. And we need to realize that each step of procedures from the provisional to the final restoration phase play a crucial role in the stability of the implants and the surrounding tissue. So in general, clinicians are familiar with the implant spacing requirements, so I'm not going to try to belabor the point, but what I want to do here is to emphasize the 1.5 and 3 millimeter spacing requirement ensure that you have the minimal bone volume around the implant relative to the adjacent teeth or adjacent implants so that we can avoid compression necrosis would lead to bone and soft tissue loss as well as implant failures. And to kind of put things in context for you, research from Tarnow and Salama show that we can have a predictable interdental papilla height when proper spacing is followed. And by correlating their studies together, we know that when the distance between the proximal contact to the interdental crestal bone is 5 millimeters or less, full papilla height of 4.5 millimeters between the implant and natural tooth can be expected. But with just 1 millimeter of interdental crestal bone resorption as a result of compression necrosis, almost half of that papilla height will be lost. So we should understand that when we violate spacing requirement, we cause loss of crestal bone and therefore loss of the vertical papilla height, which create a black triangle phenomenon that we see too often. And that black triangle is not just only a foot trap, it's absolutely detrimental to the aesthetic in the anterior region. So in terms of soft tissue biotype and phenotype, with respect to the stability of implant and implant health, what do we actually know? Well, study in the 70s and 80s showed the difference between thin and thick biotype. In terms of phenotype, original study from Benghazi group in the 90s say that we do not need carotid tissue in order to keep the implant area clean. But that same group later republished the result to show that the lack of carotid tissue negatively impact crestal bone loss around the implant, regardless if you have a 2 millimeters of alveolar bone around the implant or not. And similarly, Linguist's group found that the patient with less than 2 millimeters of carotid tissue have on average 1.5 millimeters of bone loss surrounding the implants. Study of soft tissue surrounding anterior implant by Chokhan also show a thick biotype group has significant smaller recession 1 year after implant surgery. So from the literature point of view, carotid tissue is important to maintain the biological stability of bone and tissue surrounding the implant. So moving on to the stature root position, which is one of the intrinsic factor. And the question is, why do we concern about it? And this is important because knowing the stature root position radiographically will help you determine ahead of time if you're going to have adequate buccal and palatal wall thickness after the extractions to place the immediate anterior implants. And it's also help determine whether you're going to have to perform bone or soft tissue augmentation to either bulk up the volume or to create more suitable site for implant placement later on. So radiographically, you need to determine if you have 2 millimeters minimum thickness on the buccal wall for you to even attempt immediate implants. It's because if you have less than 2 millimeters, you're going to have premature resorption of the buccal plate, which will lead to a failure of osteogenesis on the facial aspect of the implants, because you're going to have premature resorption of the buccal plate. And this 2 millimeters minimum thickness is an absolute must, regardless if you plan to do grafting at the implant surgery or not. So on the cone beam scan, by scrolling through the cross-sectional image, you will be able to do several things. One is that you want to see the root position within the socket and the bone and the volume of the bone, of the surrounding bone. Second, you'll be able to visualize any bony defects such as fractures, dehiscence, or fenestrations. And third, you'll be able to locate adjacent structures such as the nasopalatal canal, the nasal floor, etc. And lastly, you will determine the amount of bone height above the root apex, because this is the bone is where, because this bone is where you get the majority of primary stability when placing immediate implant in the anterior zone. So in this article by Chokan, he kind of give us a guideline to determine if immediate anterior implant is indicated. So how does it work? So on your screen from left to right, the socket configuration in class 1 and 2 are more ideal for immediate anterior implant because you have palatal bone as well as apical bone beyond the root apex to obtain primary stability. In contrast, in class 3 and 4, they are not ideal for immediate implant because a thin buccal bone that is very susceptible to resorption, and the volume of the bony housing surrounding the socket is not adequate for immediate implants. Fortunately for us, class 1 and 2 are 87% of what we normally encounter. And for immediate anterior implant, we want to select a socket configuration that fit in class 1 and 2. And other take-home points from this article that I want to emphasize. First is the importance of proper diagnostic technique by using three-dimensional imaging like cone beam scan, as well as the need to have to be able to do extraction atraumatically, so to preserve the buccal bone. Second, I want to emphasize that the socket dimension and the spacing requirement, because of those dimensions for anterior implant, we should select the implant side that is narrower in diameter but longer in length. And this is an opposite to the recommendation for posterior implant, where you would have shorter but wider diameter. So now we want to talk about the intrinsic factors. So in terms of how to position the implants, Garber and many others emphasize that the implant position is not dictated by the position and the contour of the, it's dictated by the position and contour of the final implant restoration, and is not dictated by the position of and volume of the existing bone. So hence they have the term prosthetically driven implant surgery. And this because if the implant position does not properly support the aesthetic and functional requirement, then the implant is relatively worthless. And they also advocate for a screw retained anterior implant restoration, because screw retained anterior implant basically means proper implant position to allow that to happen, which means that we have the ability to preserve hard and soft tissue long-term and short-term, as well as give us the ease of restoring and maintaining the peri-implant hygiene over time. And the benefit of having a screw retained restoration far outweigh the benefit of a cement retained restoration. And really this concept is widely accepted in the literatures, both by surgical and restorative colleagues. So let me review the illustration you see on the screen. So for the most part, the position of the position and the angulation of the implant restoration, which I call it in gray color, is the same as the position of the extracted tooth that was there previously, right? The only difference here is that you try to replace the root with an implant. And in order to have prosthetic access hole, which represented by the two solid red lines, accessible from the palatal wall of the restoration, the implant must be placed palatal to the incisor edge. Let me emphasize again, the implant must be placed palatal to the incisor edge. The implant therefore is anchored to the apical and the palatal bone. And what are other requirements? So let's say we have a central incisors that ready to be extracted. And after the extractions, the remaining buccal wall must be 2 millimeters or more. And this is shaded in the red color as you see on the screen. And when you're ready to start your first pilot drill, you would use the Neo-Biotech liniment drill, look like just like this one. The angulation of the liniment drill should be relatively parallel to the inner side of the palatal wall. And once you're happy with the angulation of the liniment drill in the socket, you will start with your 2mm twist drill and so on. And to avoid the slippage of the twist drill, you need to make sure that when you drill with the liniment drill, the drill is actually 3 to 4 millimeters in bone. And remember that all drilling must be done with plenty of saline irrigations. And after you complete the final osteotomy, you're ready to place your implants. As the implant is being rotated down the osteotomy, the counter pressure from the palatal wall will tend to kick the implant toward the facial. So you need to be aware of that and try to keep your angulation steady. And please understand that you must avoid pushing on the implants toward the buccal wall during placement, especially the first coronal three-half coronal of the buccal plate. So now, from the day-to-day clinical setting, especially in a busy dental practice, a simple 3x3 rule that I'm going to give you a quick reference on how to decide where to put your implants. And what this rule is saying that the first 3 millimeters saying that the shoulder of the implant, especially the outer shoulder of the implant that's facing toward the facial, at least 3 millimeters apical to the zenith of the final implant restorations. The second 3 millimeters means that the center of the implant at least 3 millimeters palatal to the future facial margin of your restoration. And the last 3 millimeters is the spacing between adjacent implants. So now, after the implant is placed, the next step is to place bone graft between the outer implant surface and the inner side of the buccal wall. And it's preferable that you have greater than 2 millimeters of gap to give yourself adequate space to insert your graft material and to accommodate for some initial resorption. You might even have to grab the outer surface of the buccal wall if you need to increase the buccal bone volume. And this technique is called the dual zone grafting concept. Regarding bone regenerations, there are two biological processes that happens. So in the simplest term, you have the resorption of the graft material as osteogenic cells migrate to the side to deposit new bones onto the implant surface and to the surrounding bone walls. Now, assume that you reach above 30 Newton centimeter, which is the threshold for your primary stability, and you have an intact buccal wall that is 2 millimeters thick. After you place your wrap material inside the gap, now you proceed with placing either a healing abutment or immediate provisional without having to place a resorbable collagen membrane barrier. So when we look at the risk level from the availability of bone and soft tissue type, the classification by Salama help us determine the risk level and the indication for immediate implant and what we need to do to make that happen. So talking about class 3, so if you are missing a portion of the buccal wall after extractions, you still be able to place an implant. However, in this particular situation, because you don't have a full buccal plate to hold the graft volume, you would need to make a flap reflection and place a membrane barrier to contain the graft material. And depending on the level of defect, you might or might not be able to place an immediate provisional. And this is a compromised situation because you will lose not all, but some amount of the buccal soft tissue, including some pupillar height. So the question now remains is that how large of a defect or how large of a deficiency that would absolutely prevent us from placing an immediate anterior implants. So here's an example. In my opinion, immediate implant in this case should not be done. And here's why. So severe dehiscence on facial of tooth number 10 and 11 was noted on the cone beam scan and was confirmed after I reflective flap. And if you encounter this scenario, I recommend that you do a 2-stage surgery. And so what you do is you perform bone and possible tissue augmentation. You will let it heal and then you go back and place your implants. And on the bottom screen, I kind of list the key item that you need to achieve in order to have successful outcome with bone regeneration procedure. So next, I'm going to play a surgical video I perform on my patient to demonstrate an immediate implants case with very minimal risk. The patient we have here have relatively thick biotype and an adequate buccal wall thickness. So the tooth number 10 had a metal ceramic crown with a cast boson core And because of occlusion with trauma and the cause of vertical root fracture would make the tooth non-restorable. And I hope that this video could help answer any question that you might have up to now. And I'm going to say ahead of time that I'm going to apologize for the discoloration of the video during the grafting procedures because my assistants accidentally put the overhead light onto the surgical film. So let's watch the video. Excuse me. So you're seeing I'm using the perotome to atraumatically remove the root. He returns the sockets to remove any remnants of soft tissue or periodontal ligament. Now, what I want you to pay attention to here is the difficulty with controlling the ligament drill due to vibration and slippage in the socket wall. So after two minute twist drill, then we do a periapical radiograph to check our angulations. So palatal osteotomy is complete. At this point, you see the palatal osteotomy is actually placed toward the palate side. And now the implant is being placed, and you see the counter-resisting force from the palatal wall try to kick the implant toward the facial. So it's really important that you keep we keep our hand and implant handpiece steady. So here we have primary stability above even 30 Newton centimeters. And now we're ready to place graft material inside the gap. So I'm kind of packing the bone down to the socket. And here I'm placing a resorbable membrane barrier, and I will explain to you why. And radiograph of the final placement. Okay, so you saw in the video, I placed a collagen resorbable membrane barrier, right? And for this patient, because I have primary stability with more than 30 Newton centimeter torque, I could easily fabricate an immediate provisional, but the patient chose not to have it. And the reasons was because of finance. And if immediate provisional was selected, then it would not be necessary to use the resorbable membrane as a method for graft containing. We can just easily contain the graft with our healing abutments. And with that being said, I personally prefer to have a provisional place, that provisional that screw onto the implant at the day of the surgery, especially for immediate anterior implants. Now, if you don't want to use a resorbable membrane, the alternative is to use a collagen resorbable membrane. The alternative is to use a PRF membrane, which is the platelet-rich fibrin membrane. It's made from the patient's own blood. You can also combine the liquid phase of the platelet-rich plasma with the bone graft material to kind of make sticky bone, which make it very, very easy for handling during the grafting. And using these techniques really accelerate the healing process. And Dr. Kim have a great lecture talking about the use of PRF and as well as AFGs a few weeks ago. Now I want to mention this. So cortical tapping is part of the neobiotech protocol for type 1 and type 2 bone that you typically encounter in the mandible. The neobiotech drill kit has two sets of cortical tapping drill for you to use as circle in red color. Because the anterior maxilla is mostly type 3 bones, cortical tapping sometimes is not necessary, particularly in immediate anterior implant case. However, if you get a lot of resistance during the implant insertion as you get close to full depth, then you would need to back out the implants and perform cortical tapping. That way, you don't over compressing the bone. Now, I want to take a minute to kind of explain how the design features on the NeoBiotech's implant can help avoid bone compression and to kind of get better primary stability at time of placement. So the implant surface conditions on the NeoBiotech implants is a sandblast acid edge surface, which increase surface roughness and stimulate bone resorption, bone formation around the implants. From the macro design level, the design includes a wider distance from thread to thread, as well as wider blade and a tapered implant body. And those two features minimizes the compression on surrounding bone, while increases the bone to implant contact area, and therefore increasing the primary stability, especially in the immediate cases where you often have to underside your osteotomy. A wider cutting edge in combination with a high thread pitch on the implants allow the implant to be driven down onto the into the osteotomy without over compressing the bone, while maximizing the initial stability. So, and in the anterior maxilla, the increase in initial stability allows fixation of the implant in soft bone, which is type 3 bones, and this enable us to load the implant at any point prior to at any point after placement. So now let's look at a case where the buccal wall is efficient, but immediate implant could still be placed with facial bone augmentations. So really on the surface, the case looked fairly non-risky, but what we have here is a severe concavity on the buccal wall beyond the red dotted lines. Basically, we have an adequate buccal plate thickness at the coronal portion of the implant, but thin at the apical portion. So after I removed the root atraumatically, I placed the implant by following the surgical guideline I briefly talked about. Next, I placed the graft between the implant and the buccal wall. And in this particular situation, I use a different approach to augment the outer surface of the buccal wall. And here's why. If my approach was to do a normal facial flap reflections, I would definitely risk exposing the adjacent crown margins due to recession and resorption of the soft tissue, right? So how I approached this was I make a semilunar incision at the mucogingival junction, then I tunneling underneath apically and coronally before reaching the sulcus, right? And then I would place my allograft and resorbable membrane and close it up. And to limit the sedation time and kind of enhance patient comfort, I indexed the implant position at the surgery so that I could fabricate a provisional after the patient left the office. And then patient returned in 24 hours for the delivering of the provisional restorations. And the gingival tissue was allowed to heal to the emergent profile on the provisional. And you have about 48 hours from the time of the implant surgery to when you can insert the provisional. Because if you go beyond that 48 hours, the micromotion from inserting and removing the provisional can interfere with the osseointegration process. So as you can see, over the course of healing, composite material was added incrementally to the gingival portion of the provisional in order to shape the tissue contour. And when it's time to restore the implants, we were able to maintain a positive facial contour. And we look at the beautiful implant sulcus. We know that this thick tissue volume of surrounding the implants will help protect the underlying supporting bones and also prevent crestal bone resorption that can jeopardize long-term stability of the implants. So ultimately, by positioning the implant palatal to the incisal edge or the curvature of the upper arch, I was able to fabricate a screw-retained metal ceramic restorations, and the gingival architecture of the adjacent teeth was preserved. We haven't lost any vertical tissue height. The patient had a small scar tissue at the mucogingival junction, as you can tell. Other than that, we have beautiful result. We have a thick band of attached canine tissue around the implant to protect against recessions we have what I call an implant triad. One is that we have a correct implant position. Second is that we have a healthy peri-implant soft tissue. And third is that we have a proper immersion profile on the restoration that mimic the shape of the root coming out from the alveolar process. And those three triads are the cornerstone in helping the patient to maintain the peri-implant hygiene long-term. And as a result, despite having, and as you can see, despite having a metal ceramic restoration, we achieve good aesthetic result. So look at another case. Here, I utilize a different approach to reserve and shaping the dental papilla. So what we're looking at here is tooth number 9. So this tooth has multiple endo treatment, but the external resorption did not resolve. The tooth was discolored and the facial gingival margin had minor defects. So the decision was made to extract and perform immediate implants. Fortunately, I have adequate buccal wall thickness here. And so I only need to graft the gap between the implant and the inner surface of the buccal wall. So with this patient, we have thick gingival biotype. The distance that I measure from the crestal bone to existing mesial contact point was within 5 millimeters range, which I abbreviated in the letter PH. And this distance, the 5 millimeters distance, according to Tarnow, if everything is done correctly, I would be able to maintain full papilla height. And from the occlusal view, what I aim for is to have the perimeter of the implant to either be at or slightly parallel to the incisal edge, which I represent by the green color dashed line. And what this does is that it ensures the distance between from the center of the implant to the incisal edge to the incisal curve is greater than 3 millimeters as recommended by the 3x3 rule I showed you previously. So now the tooth was removed atraumatically, the implant went in as planned, and I verified the mesial-distal angulation with conventional radiograph prior to placing the implant. And with anterior implants, what I want to do is I want to select a narrow diameter but long implants, so not to over compressing the surrounding bone in the anterior regions. Now, here's what I did different with the provisional. Whenever possible, I save the extracted anterior tooth because 9 out of 10 times, the extracted tooth is the perfect provisional material. And let me show you how we can use it as an implant provisional. So what I do is I section off the root, and when sectioning, I follow the curve of the CEJ, which is represented by the red color lines. I hollow out the lingual side of the tooth, irrigate it well, perform a chair side pickup using a provisional cylinder with your choice of light cure material like composite or bis acrylic like bis GMA. And with the extracted tooth, we use the original contour of the crown to shape the immersion profile. Now, you have a temporary that is, now with this technique, you have a temporary that is not only biological compatible, but you can see it's highly aesthetic compared to the conventional provisional material. So how much time does it take you, and can you be compensated fairly for your time? To be honest with you, this takes no more than the time that would take you with the conventional provisional technique. And based on my experience, this technique probably take less time because you are not starting from scratch. Remember, folks, you can charge out this procedure just as you charge out for any other procedure, and you set a fee for this particular service dependent on your practice locations. One word of cautions, just make sure that you don't make this look too good because your patient might not come back, and it happened to me. And you would want to do this pickup technique prior to placing the wrap material so that you can avoid contaminating the wrap material or leave any kind of pieces of foreign material inside the socket, which can cause infection. So you can see from the right pictures that some of the wrap materials kind of oozes out from the socket as the provisional was put in place, and the final radiographs show I took the final radiograph to kind of verify that the provisional was seated completely, because incomplete sitting of the provisional can create small micrograph, which create kind of a crevice for bacteria to thrive and cause damage to the surrounding bones. So the top photo was taken after the provisional was placed on the days of the surgery. And as you can see, the provisional has a natural shape and contour similar to that of the contralateral tooth. And the lower pictures were taken 1 week after the implant surgery. And you can see that with this provisional technique, the tissue healed remarkably. And from the customer service point of view, our patient didn't have to suffer from the feeling that he would have to wait months until he can have an implant restoration that resembles his old tooth. So really, in my honest opinions, immediate provisional technique like this one I just showed you is an awesome service that we can offer to our patient. So this photo taken at the final impression appointment, again, the peri-implant tissue healed remarkably. And by having the ability to place immediate implants and immediate screw retain provisional, we were able to preserve full natural pupillar height and maintain that positive facial gingival contour. And look at it now, I think we even managed to gain some tissue height. And here's the photo of the patient with the final restorations. So overall, the surgical and aesthetic result more than met the patient expectation. And it's a good day when both the patient and yourself feel that way. And here we look at the restoration from the lateral view. And in the final radiograph, you see that the presence of the interproximal crestal bone, which is the key for preserving the pupillar height. And now remember this, if this crestal bone was, if we treat this patient with delay immediate implants, this interproximal crestal bone would have been resolved long before. And when this happened in patient with moderate to high smile line, like the patient we see here, he would have showed the black triangle, which is not very aesthetic, but because we was able to extract the tooth and place immediate implants, that interdental crestal bone was reserved. As a result, we preserved the interdental pupillar height. So, just kind of, a statement that we would think that soft tissue can cause a lot of issue, but just remember the bone always set the tone, because when the crestal bone is there, we always be able to maintain the soft tissue. And the final case I want to show you today involved guided implant surgery for a missing tooth number 26 that has moderate buccal wall defect with limited mesial-distal edentulous space. If the implants, in this case, encroaches on the area of tooth number 25, the risk for developing periodontal defects and losing tooth 25 is high. So in this case, precision is an absolute must. And to help with that, the patient and I elected for guided implant surgery with the Neo Navigas drill kit. So I designed the guide, and Neo Biotech helped me printed the guide using the 3D printer. And buccal GPR was also performed on the same day. Personally, I like this drill kit from Neo Biotech a lot. The upper portion of the drill kit fit precisely in the metal sleeve, which you will see why. And that metal sleeve is fit precisely, is already installed in the surgical guide, so you don't need to have a removable keys holder that remove in and out. With other drill kit system, you would have to switch out to the different key diameters to fit different side of your drills. And during the surgery, trying to hold the keys and trying to hold the surgical guide with one hand while drilling with the other hand, this can be very cumbersome. And now I'm going to play the videos to give you an idea how the surgery works with the Neo Biotech guided kit. So now I'm just kind of continuing with the sequencer osteotomy drill. Now I want to mention here is that cortical tapping is necessary because you have type 2 bones in this case. And for a smaller edentulous site with limited bone volume, it's recommended that we do this manually with tactile sensations instead of using the implant motor to do the tapping. And when precision is required, it's also recommended that you manually insert the implant inside into the osteotomy with your fingers and to use a torque wrench to kind of deliver the implant to full depth. And our primary stability, as you can see, above 35 Newton centimeter. The buccal wall was intact after implant placement, so now we proceed with doing the facial GPR procedure. So bone graft was placed, and now we complete the procedure with suturing. Okay. So a few months later, we were able to, I was able to digitally locate the implant location and the surrounding soft tissue with the intraoral scanner that we have in the office. And the lab fabricated a screw retained zirconia restorations. And you can see that the position of the implant was placed toward the lingual, but still in the bones. Okay. And the final result, I apologize for the fuzziness of the photo, because I took the photo with my cell phone, with my iPhone, as a matter of fact. However, both the patient and I could not be more pleased with the final result. So to summarize the things I talk about today, so we talk about the biological constraint that dictate the clinical decision in terms of choosing between conventional versus immediate implant placement. We talk about implant spacing and the amount of vertical soft tissue we can expect in relation to the alveolar bone crest, and how different gingival biotype and phenotype can assist us in long-term maintenance of the anterior implants. We talk about different risk level and the appropriate treatment protocol based on the Semilunar immediate implant risk classifications. And I went over extensively the actual mechanic of placing the implant, particularly for anterior immediate implants. And I want to emphasize that we should approach anterior implant placements as a three-dimensional exercise. And our biggest priority is to have a screw retained anterior implants restorations. Also, I want to emphasize that we need to do the extraction atraumatically so that we can avoid damaging the buccal wall, as well as the interproximal crestal bone. And also remember, in the anterior implant, you want to select an implant with smaller diameter but longer in length. And lastly, we talk about the benefit of gingival tissue shaping using different type of provisional material, one of which material is the actual patient own tooth. So to wrap this up, I really want to thank, I hope that you enjoyed this presentations. I want to thank you for lending me your time, and I hope to see you in future webinars. My email address is on the screen in case you need to contact me for any reasons. And now I'm more than happy to answer any question that you might have. Okay, so the first question we have from Dr. Danila: which instrument do you recommend for packing the allograft after the implant is placed? It seems difficult to ensure that the particulate will make it all the way down to the apex of the socket. Great question. So in the Neobiotech drill kit, if you lift up the top portion, there is it's almost look like a periodontal probe, but thicker side, and it's small enough with a flat bottom that allow you to pack the bone down into the socket. So second question from Dr. Song: the case you shared with guided surgery for implant number 26, what was the diameter used? Have you thought about using mini implant in that spot? And thank you for great lectures. All right, thank you, Dr. Song. So the implant size I use in that case is 3.5 millimeters diameters. I'm not very keen with placing mini implants. Just the fact that with mini implants, is extremely narrow. And from the literature point of view, I haven't seen good long-term result with media implants. Especially, I see a lot of fracturing of the implant, and difficult, and the clinician would have difficulty removing the fractured portion of the implants if that is the case without severely damaging the site. So I hope that answered your questions. Any more questions, guys?
Doctor, there's more questions
Okay.
from the Q&A.
All right. I just opened the chat box, so let me answer from the Q&A. What would you do to achieve free tension primary closure? All right. So to achieve, this is from Dr. Nguyen, Dr. Pham Nguyen. To achieve free tension primary closure, you need to make sure that you have proper release of your flap. And if you feel like if the flap are not covering the side, then you need to do periodontal release incisions, or making your vertical incision more apically, or making the base of your flap wider than the coronal portions. That is one way to ensure that you have a tension-free flap. Next question from Dr. Pham. What is cortical tapping? Great question. So cortical tapping, if you look at the drill that you use for drilling the osteotomy, the drill is actually perfectly parallel, right? But our implant is tapered with wider coronal section. So cortical tapping basically create a wider diameter at the coronal portion of the bones, and also kind of put in these grooves that matches the thread on the implants, if that makes sense. And coronal tapping is important because it prevents you from over compressing the bones, which can cause bony necrosis and causing loss of both hard and soft tissue. Next questions. What are you using to reflect the lip during the surgery? Okay, so the particular piece of instrument that I use is called the Optigate. It's a piece of a one-time use plastic that I use to kind of reflect both upper and lower lip, and it works really, really well. There are other things that you can use. I found that the Optigate, which you can search online, is very kind to the patient. What is anonymous attendee? So what is semi-lunar flap design? Could you explain to me? So a semi-lunar flap design, and the way it's done is done apically to the mucogingival junctions. And the reason why you pick this particular design instead of flapping it conventionally is because you don't want to. If you have a case that requires a lot of delicacy, like you don't want to risk the risk of tissue recession, because every time you make a conventional flap, you typically can expect about 0.3 meters of bone loss, and therefore you're going to have some minimal of resorption, recession of the soft tissue. So semi-lunar designs basically prevent from doing that. It's a safe way of doing it, and also you can see that with the semi-lunar incision design, you'll be able to tunnel really, really deep apically, as well as tunneling up coronally to place the graft wherever you want, and you will ensure yourself absolutely to have primary closure of the of the flap. So I hope that answered your question. Can you briefly review how you make the provisional from the natural tooth? Okay, great question, and this is from Dr. Klein. So Dr. Klein, so how he does it is that after the tooth is extracted, my assistant would, irrigate and capicize the tooth. And then I would take a handpiece, a high-speed handpiece, and then trim the root off, and kind of follow the contour of the CEJ, because we want that contour of the CEJ to kind of give us the template to shape our immersion profile on the provisional, right? And how I does it is that prior to the extracting the tooth, I make a quick templates. You can do this with composite, or you can do it with a suck down matrix, because that template, what it does is that after I section the tooth and make the hole on the palatal side of the extracted tooth, I put the tooth inside that matrix, and that matrix also had the hole on the palatal side. And then, so that tube will be sitting over the provisional cylinders, which you can purchase from Neobiotech. And then I would flow, I typically use flowable composite because it worked really fast. I put flowable composite inside that palatal hole around the provisional cylinders. Lacquer it, you don't have to fill it all the way. All you have to do is just fixate it, the tooth onto the provisional cylinders. Once you've done that, then you will remove everything out together, and then you will fill in the rest of the immersion profile with flowable extraorally. So I hope that answered your question. What is your feeling about socket shielding? Socket shielding worked great. If if the tooth is intact and doesn't have any type of inflammation or prior disease like external root resorption and things like that, then socket shielding worked great because it's really helped. It's kind of it's a patient own material, so to speak, and the combination of socket shielding with allograft really regenerate bones well, and also because when you do socket shielding, you leave fragments of the tooth, especially if you do an anterior implant, that will be the facial fragment of the root. And that little facial fragment help maintain the facial buccal plate, as well as give you more primary stability when placing the implant, because part of the implant will also be anchoring on that piece of fragment. Next question from Dr. Guzman. Are your immediate anterior implant in full occlusion? So you talk about immediate provisional. Majority of the time they are. However, if patient have class 2 division 2 malocclusions, which I explained to you earlier in the lectures, I tend not to, and I still play provisional in that way. However, I would completely take it out of excursive occlusion because implant is good at taking vertical forces, but not very good at taking side lateral forces. So if you want to be careful, yes, you can play a provisional and then just take it out of occlusion. Dr. Silvestri, excellent presentation. Thank you, doctor. Dr. Guzman again. I think, what Newton centimeter do you recommend for full occlusal function in immediate placement? So Dr. Spencer Park have an excellent presentation about implant stability, whether for a conventional loading technique or immediate loading technique. In my opinions, for a single implant, especially immediate implants, as long as you have 30 to 35 Newton centimeters torque, you can do immediate loading. If you have less than 15 Newton centimeters, then I would recommend you to place a healing abutment or a provisional that out of occlusions. So that way you allow the implant to have full osteogenesis before you come in with a final restorations. Dr. Kim, is there any more information or link to fabricate a provisional with extracted tooth? Hey, Dr. Kim, email me and I can send you more photos that way, okay? Dr. Park, have you thought about bone graft using the Vista technique that use vertical vestibular incision instead of the horizontal semilunar incision that use horizontal incision? Excellent question. Yes, you can do it that way too. It's just what you feel comfortable doing. For me, like if I need to have a quick access and I don't need to go, extremely apical to the implants, I tend to use the, the semilunar incision technique, because that way I have a good, visibility of, the buccal wall, it's especially the buccal wall immediate to the implants to know where to place my graft. Plus, I'm not, worrying about having to retracting the lip very high up in order to do that. Dr. Lim, thank you for your beautiful and energetic presentation. Doctor, do you use a lot more CGF or PRF membrane versus other membrane? What membrane that we buy, and when recommend the PRF or CGF membrane? I use a combination of both, to be honest with you. Even when I'm, doing the platelet-rich fibrin technique, I actually even dip my collagen membrane in the plasma and then place it on the patient. And I found that the tissue healing happened a lot faster and more predictable that way. What type of membrane I use? You can use any type of collagen membrane, to be honest with you. The type I typically use is the chorion amnion membrane, which is it made it's extracted from a pregnant woman, and it's contained a lot of tissue growth factors that help with soft tissue regeneration. So yeah, chorion amnion membrane is what I use, but it's just another collagen membrane type, and you can use a variety of them. When you recommend using the PRF membrane, I would say anytime you can use PRF membrane, do it, because I bet I will tell you, if the patient come back in 3 days, you will see the healing is remarkable, because the PRF membranes contains a lot of tissue growth factors, and it's really helped with enhance the revascularization and the development of new epithelial tissue quickly, and it's really helped me. Dr. Nguyen, are you not using connective tissue wrapping for aesthetic zone? No, I'm not. If the patient doesn't need it, especially if I already have, I don't have any type of recession prior, and if patient have thick carotid tissue, at least 1.5 to 2 millimeters. And I mean, I prefer 2 millimeters or more, but if patient fall into that category, I do not need to use connective tissue graft. The key is to do, non-invasive surgery. So if we can, proper diagnose the patients and do the least while achieve the most, then we should aim for that way. Thank you. And what is used for difference between CGF and PRF? Okay, so PRF is, is the concentrated portion, and what it is basically, it's like a glue that you can pull out after you centrifuge the plasma, and then you can compress that piece of membrane, that piece of plated rich plasma, and then use it as a membrane. Whereas CGF, so CGF is, well, CGF means different things. CGF also means PRF, because PRF is highly concentrated growth factor, right? But when you talk about CGF, I think you're talking about the liquid phase of the PRF, and that liquid phase is what you use to make your sticky bones. And Dr. Kim has a good lecture about that. Dr. Fuller, thank you, Dr. Trinh, very informative. Thank you, Dr. Fuller. He's one of my colleagues. Dr. Kim, are you referring to the thickness or the height of the buccal bone when you say you need 2 millimeters? So when I say I need 2 millimeters, I'm referring to the thickness of the buccal plate. All right, any more questions? Anyun, do you have any more questions?
Doc, I think you already answered all these questions. Is there anything else you'd like to mention?
No, I mean, again, I just want to say thank you to everyone, and I hope you and your family, your loved one, continue to stay safe and healthy. And I bet you we are, very persevere, resilient, and we will overcome this, health crisis. Again, thank you, and I hope to see you at future webinar.
All right, thank you, Doctor. Thank you very much. And I also leave Dr. Trin's email address on the chat. So it's dr.owentrin@gmail.com. If you have any further questions, please email Doctor. He would like to answer some of your questions. And now I will just jump right into today's announcement. And I want to say thank you, Dr. Trin, again for your presentation. So, and please stay connected with us on social media. Our Facebook page is Neobiotech USA, and our Instagram is neobiotech_USA, and also our YouTube is Neobiotech USA as well. So stay connected with us on social media. And if you are interested in taking our webinars, you can find more upcoming webinars in our website at www.neobiotechusa.com and click the webinar at the top, then you'll be on our webinar page. And we have another great webinar coming up today at 2 o'clock Pacific Coast time on advanced bone grafting made easy with Dr. Jeffrey Platt. And we will announce a special promotion during this webinar, so don't miss out. And also starting May, we will have 2 webinars every Mondays and Thursday, one in the morning from 11 to 12, and one in the afternoon from 2 to 3. And all these courses are first come, first served basis, so please register in advance and reserve your spot. So for Dr. Trin's also be lecturing on Thursday, May 21st about autonext treatment planning and surgical and restorative sequencing. So also mark this on the calendar, and the time is from 2 to 3 p.m. Pacific Coast time. So the day is May 21st. So this is the next week's webinars. The first one is on Monday, 18th from 11 to 12 with Dr. Mark Chen on fundamental of ridge splitting. And then the same day at 2 o'clock, we had a basic implant surgical placement of lateral implants with Dr. Kent Wong. And on Thursday, also the part 2 with Dr. Kent Wong again. And the afternoon with Dr. Trin on all on X. So I'll save all these dates. And also we have more webinars coming up and added in our webpage as well. So the first one is on the May 25th with Dr. Dennis Smiler on the session 1 of the planning and surgery of extramaxillary zygoma implants. And the session 2 will be on Thursday, May 28th from 11 to 12. And also we have the Dr. Mark Chen on 28th on fundamental of bridge augmentation with GBR at 2 o'clock. So you can also find more of these in our website. And now you can also watch our previous webinars under this previous webinar tab here. And you, if you miss any of these great lectures, you can just go to our webpage and click on the previous webinar. You can watch all these free webinars. And thank you very much for those who stay into the end. And also, as part of our ongoing effort to provide a better continuing education courses, we would like to request your feedback. So one of our sales rep will email you this link to complete. And this form is very easy. It should take no longer than 5 minutes to complete, and it should look like this. And I want to say thank you again very much for participating in today's webinar. And we hope to see you again. And I want to say thank you again, Dr. Trin, for your great presentation as well.
You're welcome.
Thank you so much. And feel free to contact me if you have any questions. Here's my email, ayong.chui@neobiotechusa.com. And I really want to hope you see you again next time. And I hope everyone will stay safe and enjoy your rest of your day. And I will meet you at 2 o'clock for our afternoon's webinar. Thank you very much, doctors, and have a wonderful day.